In the maternity ward, a patient rests hours after delivery. While the postpartum period is typically a time of recovery, the physical stress of childbirth can act as a trigger for a rare, silent medical emergency. Down deep within the bloodstream, everything initially appears normal. Red blood cells glide smoothly along a healthy, intact endothelial lining. Then, rogue autoimmune proteins called antiphospholipid antibodies, or APL, enter the circulation. This animated vector model shows how they attack. The glowing Y-shaped APL antibodies lock specifically into beta-2 glycoprotein 1 receptors on the surface of the endothelial wall. Once bound, these antibodies trigger the intracellular mTOR pathway and force the cell to upregulate prothrombotic adhesion molecules and tissue factor. This biochemical shift turns the endothelial cell into a pro-inflammatory, procoagulant surface. With thousands of receptor sites now activated, the vessel lining becomes a biological trap, creating a volatile environment primed for a systemic cascade. Sensing the injured lining, platelets rush to the site. They rapidly change shape and stick violently to inflamed walls, attempting to repair the damage. These coagulation pathways activate in overdrive. Tough fibrin strands weave rapidly through the trapped platelets, building massive, obstructive blood clots. This quantitative flow model illustrates a process known as consumptive thrombocytopenia. Because these aggressive local clots consume so many platelets to build their structures, the overall circulating platelet count in the rest of the body drastically plummets. Packed tight with trapped platelets and rigid fibrin webs, blood flow through these microvessels completely halts. Because this clotting erupts across thousands of tiny vessels at the exact same time, the localized blockades fuse into systemic circulatory failure. On the outside, this microscopic clotting becomes visible on the patient's skin. We see a branching, purplish-blue net-like pattern known clinically as levato reticularis. The discoloration is a literal map of blocked microvessels, suffocating the tissue just beneath the surface. Deeper inside, the damage is lethal. Starved of oxygen, major organs, the brain, the kidneys, and the heart, simultaneously undergo acute ischemic failure. When 3 or more organs fail at the same time, or within a single week, the strict clinical diagnosis is definite catastrophic antiphospholipid syndrome, or CAPS. With 3 or more systems failing simultaneously, mortality rates range from 30 to 50%. Survival depends on clinical intervention that can outpace the cascade. Inside the ICU, the medical team races to initiate a life-saving protocol. The required countermeasure is triple therapy, a multi-pronged assault designed to dismantle the physiological pillars of the disease. The first pillar is intense anticoagulation using heparin. Slicing through tough fibrin webs, it halts clot progression and breaks the structural integrity of the blockades. The second pillar relies on high-dose glucocorticoids. Cascading over the injured endothelial lining, they extinguish the inflammation and return cells to a calm, stable state. This schematic illustrates the third pillar, plasmapheresis, or IVIG. Acting as an artificial purification system, it addresses the root cause by physically extracting the dangerous APL antibodies out of the circulatory loop. With the antibodies eliminated, the inflammation suppressed, and the clots neutralized, vibrant, oxygen-rich blood flow returns to the organs. For patients with small vessel thrombosis and consumptive thrombocytopenia, this triple therapy approach reduces mortality by 33% compared to any single treatment.